Hi, and welcome to the Restorative Wellness Clinicians Corner, a video series exclusively for functional health professionals, where we interview the top experts in the latest research, products, tools, and best practices for getting your clients exceptional results. So welcome everybody to this episode of the Restorative Wellness Solutions Clinicians Corner. I am super excited to be chatting with our guest today. We have Dr. Aaron Hartman here with us, and he is a clinical researcher who has been involved with over 60 clinical studies. He's the founder of the Virginia Research Center and is currently serving as an assistant clinical professor of family medicine at the VCU School of Medicine. In 2016, he founded Richmond Integrative and Functional Medicine, and he now helps patients identify leverage points in key areas of their lifestyle and health that harness their body's remarkable power to heal and begin living the vibrant life they deserve. He has become the go-to doctor for difficult and hard cases in Central Virginia. Welcome, Dr. Hartman.
It's great to be here. I'm really excited to talk about this topic that's near and dear to my heart and share the little pearls I've been learning over the last several years.
Yeah, I'm really excited about this because I think hypermobility is one of those things we hear that term a lot, and I think many of us have sort of preconceived notions of what it means, but I don't think any of us have really, I know a little bit about your work, and I think that the scope of the impact of this hypermobility is something that most of us are not aware of. So I'm really excited to dig into that. Before we do, though, I know that this work is very personal for you. Can you share a little bit about your story of how you shifted from conventional to functional medicine?
Well, it actually started with my family, particularly my daughter. My wife, who is a pediatric occupational therapist, one day just asked me, hey, we want to bring a little girl in our house and foster her, and we ended up adopting her. And during the process, during transition from the foster adopt, the GI specialist recommended us cut a hole in her stomach, put a feeding tube in her stomach so they could pour formula into her belly because a piece of paper, a growth chart, said my daughter was small for her age. So Becky and I discussed it, and we talked about how chewing and swallowing is important for learning how to talk and speech development. About how if you crawl before you walk, and there's a lot of neurological and neurodevelopmental phases you have to go through, and putting a tube in a kid's belly would totally block that. And even though she was never supposed to walk, she was never supposed to talk or crawl. She was literally a vegetable when we got her. She didn't interact at all. We had hopes for better for her, and so we opted not to go down that pathway. We subsequently got reported to Child Protective Services for child neglect, which was always fun. Yeah, that's a pretty typical thing in the special needs world when you go alternative routes. And the trigger was 6 months later, Becky found a growth chart for kids with cerebral palsy, which is what Anna has, and she was right in the middle. So it was like this light bulb. The specialist, the pediatric gastroenterologist at USF, University of South Florida, had no idea there was this. My daughter was normal, and they were going to proceduralize her simply because the typical chart, the typical kid said my daughter was small. And so that was like the N-shaped Cape Canaveral that has now become a mile at the moon, where I kind of went off from there. A couple of years later, an ophthalmologist, well-meaning, recommended us do eye surgery, and we're like, she has an issue with their eyes that kind of bobble around. So we just opt to do something else. And so it's been every time we've hit a roadblock where someone's like, you need to do surgery, you need to do this spinal cord stimulator, you need to put a backlift and pump in her for spasticity, you need to do these things. Every time we've hit that wall where she stopped progressing, we said, wait a second, I've researched and gone on. She's 17 now. She was never supposed to read, and now she can read. She's able to type as well and can read actually emails from people. She's in our house. She actually cleans out the dishwasher now and does a lot of stuff. She can do most of her self-care. And so she's gone from someone who should have been a vegetable and basically been pretty bad off to a kid who's really lovely and nice and, the love of my life and the bane of my existence. so, but it's like, and that's in early on in the process, I started saying, hey, this is the kind of cool stuff I'm learning with genetic modification, how you can use nutrition to change genes and gene SNP testing and all the stuff your people are probably familiar with. And so I started saying, let me try this with patients in my clinic. So I started trying with patients. And over years, I started having patients with chronic fatigue and fibro get better, and then just kind of went off the path even further and started a clinic, functional medicine clinic. And so it's just kind of continued to evolve. And now I'm doing lipid therapy and a bunch of other stuff. And hypermobility is one of these things that kind of came across my path as I continue to research complex cases, people with Lyme who don't get better, people with chronic fatigue who don't get better, people with mold issues who don't get better, mast cell activation, autoimmune issues, all those things, and realize that the connective tissues are a vital thing that links a lot of these seemingly unrelated health issues that no one's talking about. And if you understand these, it actually affects how you treat patients. So that's kind of led me into what I'm doing now. And if I keep on doing what I have been doing, I'm sure it'll lead me to somewhere else in the next couple of years as well. So.
Well, this is fascinating. And first off, I mean, congratulations on and good for you for following your heart and not just accepting what you were sort of handed when it comes to your daughter. I think that's wonderful. I love the way you say that in light of your life and the bane of your existence. That means she's the perfect 17-year-old. That's exactly what she should be doing right now, right?
Yes. Oh my gosh, yes.
That's so great. So I want to dig into hypermobility, and just as a starting point, can you just define it in its simplest terms? Because I know there's a range.
Yes.
Let us know what is this that we're talking about here.
At a basic level, benign hypermobility is simply your connective tissues are a little loosey-goosey. It's actually a genetic autosomal dominant trait. And so what results is typically people notice their joints are hypermobile. It's the person who can do cool tricks, the yoga people that do crazy stuff. It's the kid in dance class who can do the spider. I'm sorry, the scorpion, just does a scorpion. And so it's typically thought of as just being a joint issue, just hypermobile joints, But the reality is the connective tissues connect everything. It's the insulation in your body, packed full of nerve endings. And so all of a sudden now, there's a connection between your body's neuroelectrical and your electrical hormonal system that the connective tissues connect, as well as the fact that they're highly innervated with sensory nerves. All of a sudden, that little loosey-goosey can cause an overactivation of your central nervous system or a constant low-grade fight or flight. And so what actually is a survival trait, there's a lot of elite athletes that are hypermobile. There's a lot of really smart, Aspergery types that are brilliant that are hypermobile. So it actually has survival benefits. But in today's world, with chemicals and toxins and gut issues and mold and everything else, what actually used to be a superpower has now become an Achilles heel. Most people go to the extreme version, which is Ehlers-Danlos, which is a very, very extreme version where people will dislocate hips and shoulders and they roll over in bed. You can actually have slippage of your skull on your upper spine and get compression of your midbrain structures, which is where all your hormones and your sleep-wake cycles and body temperature stuff is regulated. So that's an extreme version. What I deal with that as well, but I deal with the average quote unquote hypermobile patient who's just a complex patient not getting better. But it's really interesting how the connective tissues literally connect all these seemingly unrelated issues. It connects them together.
Yeah, that's really fascinating. And you think, because you think hypermobility, I mean, I literally think, oh yeah, I'm double jointed in my thumbs. I'm not thinking about the fact that hypermobility in one part of the body could actually reflect like that sort of stretchy connective tissue everywhere. And when you think about connective tissue, I mean, it literally is, in the word connective tissue, it holds it together. Right. And thinking about the ongoing stress that would create on the system. So you touched a little bit. So there's a spectrum of this. So we have it just, so you called it benign hypermobility all the way to the Ehlers-Danlos syndrome. Can you tell us how prevalent is this?
So that's really tricky. So the most severe form, Ehlers-Danlos, the literature's get different numbers. About 1 in 100 people have the most severe form, which, as a medical doctor who at one point in time was seeing, hundreds of patients in my clinic a week, you should see it on a weekly basis. However, the benign hypermobility, 20% of kids have this. And this is where the literature gets kind of tricky because you don't know what you're looking for unless you actually know what you're looking for. And so there was this one college, it was a study looking at college students, and it showed that 12.5% of college students had it. There was one looking at elderly adults, showed 130 had it, and there's a study showing 20% of kids have it. And I think that reflects the fact that as people age, the expression changes. And if we only look at hypermobile joints, those 20% of kids don't disappear. It's just their expression changes. And so one of the interesting things about hypermobility is people's fascia will actually tighten as they age. And so the person who's hypermobile when they're younger gets a tight core, a tight back, tight hamstrings, their neck gets tight. And so they seem to get tighter and they're not as hypermobile. And it's just their body compensating. So as we age, the numbers go down, not because people get better, but because the phenotypic expression changes and people don't know how to, via physical exam or interview, actually account for that when they're seeing patients. But 20% of kids, that's a lot. That's a whole bunch.
I'm having, I don't want to make this all about me, but I'm having quite a moment here because I'm actually putting some pieces together. I make, to say about my thumbs, which are double jointed, but I remember very specifically seeing a chiropractor way back in the day, long before I ever studied in health at L. And I was at the time doing Bikram's hot yoga all the time. I love
Ooh.
Yeah. And it was like the only time I felt good. Like I felt amazing in there. And I remember she looked at me, there was several things where she was like, maybe like, if you don't do this dietary change. And one of the other things was, if you don't stop, if you don't stop yoga, she's like, I can't help you. And I'm not going to even see you. And she explained, she said, you already have loose ligaments, which made no sense to me because I felt so tight, but you've just explained it.
Yeah.
And all the places that you just explained are exactly where I felt tight. And the only time it felt good was when I was in yoga. And she said, what's happening is you have these loose ligaments. And when you overstretch it, it feels good because your brain is connecting in, like you're actually activating those neural connections, but making it worse. Is what I'm saying an example of what you're talking about here?
Absolutely. Bikram yoga. And I have some patients that are yoga masters and we debate because there's like 15,000 forms of yoga. But that hot yoga, yes, because it makes those connective tissues looser. And so you're more prone, one of the issues with hypermobility is this idea of passive versus active stretching. And so passive stretching, which some yoga stuff requires the joints to hold them in place, you can actually permanently stretch those joints doing passive stretching if you're a regular person, especially if you're hypermobile. And so you have to focus on active stretching, which is actually engaging the muscles to shorten the length of the joints for stability in shoulders and neck and spine and back and ribs and hips. And even obviously patients will come to me because they have pelvic prolapse, they've had kids, and now they're having issues, these are female patients, with their bladder prolapsing and urinary issues. And I found out they're hypermobile and they're more prone to the postpartum stretchiness and prolapse down there. And it's like, okay, you can get surgery on those connective tissues, which will have more scarring and you're more likely to have side effects. We can focus on PT, we can literally change your whole pelvic floor. So it's really one of those things that once you start connecting the dots, it's like, oh yeah, I've had that issue and that issue. I routinely go on these interviews like this and I'm diagnosing people's hypermobility. There's one person actually from our mastermind actually that I did an interview with Monday a week ago, because today's Monday.
Today's Monday.
Okay. Yeah, I know, kind of crazy. And as we're talking, she had a lot of pain when she was younger. A lot of joint issues, and she realized if she did core strengthening, and the pain went away by the time she was in her early 20s. And so we're talking about sleep apnea and joint issues, and she's like, I think I'm hypermobile, but her whole practice is actually core strengthening for whole body health. And she kind of figured it out intuitively, which was really fascinating to me because there's so many people who actually intuitively know, like they figure things out and they just go with it versus the scientific science of no, you don't have a diagnosis, so it can't be so kind of thing.
Right. Well, I'm fascinated about this idea that the expression changes as we age. So is there anything else that changes in the expression? And maybe this actually speaks, I should take a step back to the bigger question of what are some other ways? I mean, we talk about the joints very specifically, but what are other cues that we can be looking at for and thinking about in either our own children or for those who work with, pediatric population who are looking at in their clients. And then as we age, what are some of the other ways, or are there other ways that the expression of this changes over time?
I mean, there are certain things that being hypermobile sets you up for. And the first thing, it sets you up for certain nutrient deficiencies. People that are hypermobile, because vitamin C is such an important part of making connective tissue, they have huge needs for vitamin C. B vitamins, particularly folic, B12, your thiamine, riboflavin. These patients, because of the methylation issues that come along with this, have a higher need of these B vitamins than typical. They also have a higher need for trace minerals and ultra trace minerals. And so all of a sudden, like, what's your diet look like in your teens and 20s and 30s. There's a higher need for protein. Women, as you may know, Margaret, women need more protein per kilogram body weight than men. If you're hypermobile, increase that 50% and then shift it to more collagen-based proteins, which our current diets are radically deficient in. So like the whole bone broth collagen craze, in my mind, I'm like, okay, if 20% of the population has this, we're just kind of speaking to that huge segment of the population. Some of the craze with the carnivore diet, for example, is actually speaking to the fact that these people's microbiomes tend to be more messed up. They have more gut issues and they have a deficiency in protein and trace minerals. And it's almost like we're resetting those things with that extreme diet that I don't typically recommend, but it's an example of how these trends can almost like be explained if you understand hypermobility is that common. But there's also association with a whole host of other illnesses, IBS issues, gut issues, autoimmune issues, POTS and dysautonomia, which I'm not sure how much your community knows about dysautonomia and POTS, chronic pain syndromes, chronic fatigue and fibromyalgia, patients with mold issues or SEERS. There's a whole bunch of these difficult mystery patients, chronic Lyme disease. One of the interesting things about this is that the connective tissues, actually Borrelia loves low oxygen tension tissues. So it likes joints, ligaments, fascia. Well, guess what? People with hypermobility already have, because of stretchiness, have poor circulation to these tissues. So all of a sudden, there are a group of people that would be more difficult to clear this. And if you're appropriately treated with the typical antibiotic, right, the whole 10-day thing, they're more likely to be the person who has an indolent, smoldering Lyme that just sits there and causes a bunch of other things. So a lot of these difficult patients that we see all the time that are kind of everywhere, mast cell activation syndrome is another one, part of the pentad super syndrome, which is the top 5 things that tend to come together. And hypermobility is the only one of those that by itself is not an illness, but can make all those things worse. And so it becomes, when you've got difficult patients that y'all work with, that you get your clients, you get 80% better, 70% better, and you get stuck. That's when I start asking, is this person potentially hypermobile? But I see patients in person. I usually figure out on an exam because the skin feels a certain way, the mouth looks a certain way, the hands look a certain way. They have a certain kind of body form that after a while you kind of get a good adult for, I think this person is hypermobile.
Fascinating. I want to dig into these. So you explained, let's go back to the nutrient deficiencies, because this is fascinating. And I just want to make sure everyone really understands it. So yes, we know that vitamin C is so important for connective tissue. So we're going to be thinking about that vitamin C need. Can you explain a little bit more about the B vitamin needs and the methylation support? Why is that extra important for them?
Well, there's a bunch of reasons. One, this group of people is more prone to SIBO and dysbiosis because of motility issues related to the connective tissues. So, and as you all know, if you have SIBO and dysbiosis, you're more prone to B vitamin deficiencies. Also, for making connective tissues, you have to spin out, if you remember the little chart, the methylation cycle, MTR, MTHFR, homocysteine, the neurotransmitters and the COMT and all that kind of stuff. That has to keep on spinning. And when you have hypermobility, you need more glutathione, which is in the lower right-hand corner, if you kind of visualize that. And so all of a sudden, you're pulling on this whole system a lot more. There's more cortisol in the system because of that activation I told you. Well, you need COMT to detoxify excess cortisol. So all of a sudden, the hypermobility, that whole pathway, if you can visualize it, it's just getting pulled on different ends. And what are some of the most critical nutrients? Magnesium, your B vitamins, some certain ones, your amino acids like glutamine, glycine, cysteine. So all of a sudden now you tend to see these, and the major ones are the ones I mentioned, but it pulls on a lot of different ones of these, and addressing those can actually help the people with the connective tissue issues make better tissues and help some of their baseline symptoms.
Right. This is fascinating. Can let's dig in. I want to start by digging in terms of the connection. And you've already made it to a certain degree, but I want us to dig in even further. We always start off with gut healing. That is, it's so absolutely integral in terms of nutrient absorption, detoxification, immune function, all the things, as I don't need to explain that to you. So can you explain, let's dig in a little even further about how this connective tissue, the whole gut is made with connective tissue, right? So,
the gut is actually, anatomically, your bowels are held in your abdominal wall by connective tissues.
Right.
So what happens is all of a sudden you get this thing called ptosis, which is a sagging of these internal organs. So all of a sudden motility is affected. So forget motility issues with methane predominant or hydrogen predominant or whatever SIBO the person has. Just the hanging of the organs will affect motility. Because of that, also you tend to have mild pancreatic insufficiency. They're more prone to low grade hypochlorhydria, again, because some of the activation of your adrenaline system, cortisol stuff, you're going to be more sympathetic than parasympathetic. And it's almost this feed forward cycle where a little SIBO, a little dysbiosis, a little motility, feeding them more and more and more. And these people, ultimately, you can do all the cool gut tricks, but if you don't recognize there's an anatomical component, it gets hard to really get at some of the quote unquote root cause. And that's where things like manual therapy, visceral manipulation can be helpful. These people learning how to do their own visceral manipulation. Movement is super, super critical. Like we talk about movement, how important it is, but movement actually helps your bowels move. If you have a dog at home, you get home at the end of the day, you let your dog out. What's your dog do? Runs in circles and poops, right? Well, I don't know if you ever I've had the experience where you're on vacation at Disney World or somewhere, you're moving around and everything works better. And you're like, I'm eating terrible. I'm eating, blah, blah, but all of a sudden I'm having less constipation issues because of the movement. And so all of a sudden this group of people needs, almost by definition, more of that movement to help their bowel function. So it becomes a bigger issue than simply doing a GI effects or GI map or whatever test your people do, and then all that kind of stuff. It's actually, there's other anatomical things that have to be taken into account.
So I love that we're going here. We actually have, and I will make sure that we link to it. We actually have a great interview from way back in the day with a practitioner who teaches about visceral manipulation, and it is so profound for those of you who haven't investigated it. Let's talk about the movement. So what kind of movement? I mean, you're talking about walking. Is that, I know that movement is one of those things we have to be careful about, right? Because we don't want to send them to a hot yoga class, for instance. But what kind of movement are we recommending? And is it different for different manifestations? Like we're talking right now about the bowels, and we're talking about that area of connective tissue around the digestive tract. Is that different for somebody where it's showing up elsewhere?
The biggest thing is if the person's hypermobile, what other symptoms they have. Because if someone, for example, has a lot of migraine headaches, pains in the back of their neck, there's this thing called these myodural bridges that actually connect from your fascia back here to the actual dura. And if they're stretched here, that can actually cause impingement of your nerves back here. So if they've got some of those issues, you don't want them running, or you don't want them doing a rebounder, because you can actually make that part worse. So it's really depends on some of the person's symptoms, as really regards to that. But in general, it's just movement in general. It can be walking. It can be anything where they're moving. I actually recommend rebounders to people for many, many reasons, especially my patients with POTS and dysautonomia, because the rebounding helps with your postural, your muscles of posture, which also help with blood pressure, with fluid movement. I tend to recommend those, but the caveat that some people's, because they haven't maintained their core, they can actually make the symptoms worse. So there's a little nuance to there. So in general, I just recommend movement, and then I specify it with the person. Are they having neck pain, back pain? Then maybe you want to do more gentle walking. Walking in general is okay with pretty much everybody. So it's just when you get into some of the other stuff like running versus rebounding versus other kind of bouncy movie things. That really depends on the person's skeletal stability, and if they've got pinched nerves or weird headaches, or some of the dysautonomia can actually be caused by this thing called atlanto-occipital instability, where there's a little bit of looseness in the ligaments that hold the skull and the spine, and they can actually compress the midbrain. And those people tend to get weird visual symptoms, bulbar symptoms like swallowing, speech issues. They can get some visual integration issues, blood pressure problems. And so it can look really bizarre or weird for those people. And those people are need a more advanced evaluation. So minus those people, I just recommend anything that gets them moving.
That's fascinating. Again, not to make it bad. You must have this. I can see why pretty much every interview you do becomes oh goodness, because I'm thinking about, I have a long history of migraines, and by and large have resolved, other than they now are always structural. I can feel I feel the chain that goes I can tell you where it starts and where it ends. And that's really fascinating. And
your people are everywhere. Your people everywhere.
They are. This is really interesting. Okay, so we've talked about, and I think it really makes a lot of sense. That's fascinating, thinking of the fact that connective tissue is literally holding the bowels in place. Let's take that and move this into autoimmunity, and specifically, what are some specific considerations with POTS and dysautonomia specifically?
With the autoimmunity, I'll make this kind of short and sweet. I mean, you're more prone to leaky gut, so you're more prone to autoimmunity because by definition, you have to have four things to have an autoimmune disease. One of those is increased gastrointestinal permeability, right? And so, and you have to have a chronic infection of some sort. And if you have SIBO, SIFO, whatever, dysbiosis, that can act like your chronic infection. So if you set you up for that, then almost by definition, you have an increased risk for autoimmunity in general. So, and it could just be low grade autoantibodies like an ANA or gliadin or an ANCA or these other endomysial, like these other antibodies that can just be low positive that aren't like quote unquote clinically relevant, but just a low grade. I see that a lot in my labs where people, I don't know if you all do autoantibodies and some of the vibrant, if you all do the vibrant stuff, but you'll see like low grade autoimmunity and you're like, that's kind of weird. You have lupus, it's like, no, you probably have a leaky gut and you're reacting with your own tissues, kind of, sort of. As far as the POTS and dysautonomia, the thing about it is, hypermobility is part of this pentad super syndrome. And one of those five things is dysautonomia. And so you have to think about, there's three kinds of dysautonomia. There's neurogenic, there's autoimmune, and there's adrenergic. And so depending on where the patient is, they might have the adrenergic type where they're always having these fits of adrenaline surges, basically. So I'm sleeping, I wake up in the middle of the night, my heart's racing. I'm sitting in a chair and my heart just starts to race. They have these overreaction to stressors. A little small thing has you go in a spiral. And that's part of this low grade overactivation because of the low grade adrenaline spikes from the hypermobility. And I'm going to take that down a little different pathway. One thing you haven't asked me about yet is this group of people also has a 400% increased risk for neurodivergence.
Oh.
Yeah, which is not just your autism and your Asperger's, but it's also your ADHD, your dyslexia, which is, there's a lot of entrepreneurs that are dyslexic, as well as being an empath, which it's amazing how many patients I see, maybe you are, where they actually have this intuition. We have some friends from our mastermind who, one says she's clairvoyant, and it's like, and she's totally hypermobile. And it's interesting how like that actually, it almost, you have your spidey sense kind of, sort of. And if you traumatize that spidey sense, guess what? It just freaks out every single solitary time. So what would have been a protective, right, for, something bad, whatever, now in our culture, society is just off the chain. And so all of a sudden that pulls into the POTS and dysautonomia, because one of the big issues with these patients is their gut immune system, is their sympathetic regulation and immune dysfunction. There's actually interesting studies looking at POTS patients doing treating SIBO, doing IVIGG, SIBO, and what was the other thing? IVIGG, SIBO, and low dose naltrexone, having actually the POTS go in remission, and you kind of do reverse engineering. What's SIBO treating? What's the low dose naltrexone treating? The IVIGG, and so all of a sudden, like, you understand how hypermobility, because how it affects all these systems, could play into something like dysautonomia, whether it's the autoimmune type, the adrenergic type. The neuropathic type is a little interesting because of the low grade stretchiness, people actually will get nerve damage. And more it's harder to detoxify heavy metals. We mentioned the methylation stuff before. So I see a lot of patients who have all the different kinds of dysautonomia. They might have some of the typical POTS where they stamp, the blood pressure bombs out, but then they overreact to stressors. And then, oh, by the way, I've got numbness in my feet. And so I see a lot of that kind of stuff in my patients. And again, the connective tissues are a huge part of that. And it does affect how I treat those patients. And one of the ways it makes all the baseline stuff that you and your practitioners talk about, it makes it even more important. It just makes all this stuff even more of a big deal.
You keep talking about the five, what you called it,
Okay. It's called a pentad super syndrome. And
can you share that?
Yeah, so it's from Dr. Afrin's work. He's the big mast cell guy. So it's mast cell activation syndrome, autoimmune diseases, gastrointestinal tract issues, which include all your dysbiosis plus IBS stuff, hypermobility, and then what did I forget? I said autoimmunity. Is that five?
You said SGI, autoimmune, hypermobility, and then was it like the infection?
Mast cell.
Mast cell. Yeah, that was the first one. Mast cell, GI, autoimmune, hypermobility, and would it be infections?
POTS and dysautonomia.
Oh, POTS. Okay.
Yeah, POTS. Yeah. And so if you see a patient with one of those, which, these things sound rare, but you
Mm.
realize, 3 million Americans have POTS, something, 1 in 12 Americans has an autoimmune disease. 20% of the population has a positive autoantibody. 30% of all ER visits, 30% of all GI visits are for some kind of IBS issue. Like these are 20% of the people have hypermobility. These are actually, if you're not seeing any of these on a routine basis, you're overlooking them.
Oh, 100. I mean, the GI and autoimmunity alone. I mean, it's just
That's probably what y'all do. Yeah, it's probably what you do all the time.
okay. Wow. Let's talk a little bit more about this. And you mentioned this with the Lyme and kind of explained how that poor circulation into that joint tissue like that creates this beautiful environment for something like Borrelia. Can you explain how this would make somebody even more susceptible to something like mold? How does that?
Okay, so so if you do the gene testing for chronic inflammatory response syndrome, you check for people's HLA-DRDQ, and there's a list of like 12 different genes. And part of those actually is there's actually a gene for hypermobility in that thing. And the newer thinking, and this is as of like a year ago with Dr. Heyman's work, because I'm in a group with him as well, is that we've delineated like the gene for, this one increases your risk for low MSH. This one's associated with SEER. This one's associated with increased risk for MARCoNS. These are actually false delineations. Any one of those increases your risk for chronic inflammatory response syndrome. I just think that's interesting because one of those genes is hypermobility itself. And part of the issue with the gene is it affects your body's ability to make antibodies to clean toxins out of your system. So part of the training is, how do you detoxify in your gut, kidneys, lymphatic sweat, all, But one of the things that I wasn't taught in my initial training was your immune system actually is part of your body's detoxification. You make antibodies to toxins. You make antibodies to your own damaged tissue.
Right.
And your immune system comes by and cleans it up and gets it out of your system. If you have poor antigen presentation, which is you don't present foreign bodies that well to your immune system, it makes them easier to build up. And the primary way a lot of these the toxins related to chronic inflammatory response syndrome are detoxified is through your bile.
Mm-hmm.
So they actually have the property of being both water soluble and fat soluble, so they can go through your tissues really easily. And so when your liver conjugates them and turns into bile, you put them in your gut. Well, now if you've got SIBO there and some other gut issues, you elevate glucuronidase, you release them and you absorb them back in. And so all of a sudden now this is like this perfect milieu of being more susceptible to mold. And if you're more prone to autoimmune issues, then you're more prone to that triggering of that innate immune system activation, which is what SEERS is. So it just it's like this, it all kind of fits together.
It really does. And if anyone here needed any more evidence for why we always start with the gut, and it's just this absolutely foundational piece, this is really fascinating. So I want to talk a little bit more about how we pay attention for it. So clearly, when we're seeing, as you shared earlier, we're seeing clients where they're not responding, like you're doing all of the gut healing and it's just sort of not working. This is when you want to start thinking about these pieces. So the vast majority of our practitioners here are unlicensed. So we're not in the business of diagnosing anything. What would be if somebody is suspecting that hypermobility is a piece of this puzzle, what would be a next step for them? You talked about the gene to identify that, but we know that the presence of that gene doesn't necessarily mean its expression. So that's another conversation. But what do we do next if we're starting to wonder, could hypermobility be a piece of this puzzle?
That's where it's hard if you don't have like the clinical kind of experience, because a lot of it's things I've just learned over the years. The most basic thing is the Baton score. And the Baton score is this test, the EDS Society has out there. I actually did a modified version of this, which I'm not sure when you looked at the webinar thing if we did, but basically it kind of walks you through this actually to figure out if you're hypermobile. But first is looking at the joint hypermobility. And I tend to use the United Kingdom criteria, not the US criteria, because they use a score of 4, not a score of 5. Okay. That's the start line. But you also, if your family history, do your kids do cool tricks? Can they do weird pretzel-y things? Could you used to do that? Do you bruise easy? Do you bleed easily? You have stretch marks for some unknown reason. These are from going through, I went through menarche and starting, going through puberty, it's like you shouldn't get stretch marks on your
Right.
thighs from just growing, right? Unless you gain a lot of weight.
Right.
Looking at people's facial features, you tend to have like a more narrowed dental arch, a high arch palate. These people are also more prone to sleep apnea, which is a big, big, big issue. If you look at people's hands, like their middle finger is longer than the palm. There's certain small things but one of the big telltale signs is when you touch the people's skin, they have this really kind of soft, gooey kind of. It's hard to describe. It's just the spit feels different. And
Huh.
so that's one that was one of my first clues when I was seeing patients. I noticed a group of people who just felt different. But as far as unlicensed practitioners, the Bait and Score and having someone look at that criteria from the EDS Society is probably the best starting point. It's not great, it's not perfect. It only gets the most extreme versions. That's where that modified test that I put together and developed kind of takes these into account and gives people a more generalized view of are you hypermobile one. It actually gives you like a score and gives you colors to figure out if you're more likely or less likely to be hypermobile.
How do you spell that? Is it BATON?
It's BEIGHTON.
Right. Okay.
Yeah, and I'm always careful to give that to people because what happens? They Google it and then they go down the EDS rabbit hole and oh my gosh, I'm going to die and I need the gene test. And it's like, yeah, it just it's always tricky with patients because they like to
Okay.
Google it. It's
Yeah.
BEIGHT.
BEI.
Yeah,
Sorry. BEI.
BEIGHTON. Sorry, that's probably my bad pronunciation.
All right. Okay. Okay. That makes more sense. Okay. So let's say they do this, or even just some of the quick things that you have shared here, somebody who has sleep apnea and could put their leg over their, what
Something,
are they? Mhm.
well, something super common like TMJ and teeth grinding. You
Right.
know, it's interesting how many people with TMJ and grind their teeth have low grade sleep apnea, and you start talking to them. It's actually related to their jaw hypermobility and the floppiness of the tissues in the back of your throat. So I see many people with those kind of issues. Or you're in your 40s getting cavities. Like, why would you start getting cavities in your 40s? You're grinding your teeth and cracking your teeth and damaging your teeth. It's just there's all these small nuances that when you talk with patients, you can pick them up and start connecting the dots.
Right. When are you going to do a practitioner training program?
Great question.
We should talk. Okay. So we now kind of know what are some of the things that we want to be looking for. Let's talk about what we're gonna do. So we've already talked about the movement. We've talked about visceral manipulation. I would imagine we're gonna really pay close attention to all those nutrients you described, right? So we're really
Absolutely
supporting vitamin C, those that methylation support, trace minerals, protein, glutathione. What else should we be thinking about clinically?
The other thing is that whole mind-body connection.
Mhm.
Many of these, unfortunately, many patients I work with have some kind of personal trauma, physical, emotional, sexual, or the healthcare system. They're traumatized by the system or just, life in general. But you got that thing is like these people are more prone to that trauma response, that stress response. And so that by itself, as you probably know, can increase your risk for autoimmune issues, gut issues, sleep disturbance, pain syndromes, a whole host of things. And so like having a really good foundation, you really need, if you're hypermobile, you really need to make your personal self-awareness, your personal care from a mental, emotional, spiritual, it needs to be critical. The diet-wise, you really need to work on nutrient-dense foods. Those ultra trace minerals, the funny thing about those things is they're largely, it's not just trace minerals like zinc and manganese, it's these ultra trace minerals that you really only get from eating organ meat or drinking tons of mineral water. You get small amounts in green leafy vegetables and things like that. And that's the reason why I like certain supplements like concentrates or other ones that actually are health-based that have those ultra trace stuff in there. So anyway, so yeah, the mind-body aspect, the nutritional aspect, and sleep is a big issue with these individuals. And again, I know it's a big issue with everybody, but because of the dysregulation that happens in the brainstem, whether it's the dysautonomia or it's this overreaction, people tend not to get the quality of sleep.
Right.
And so that's where, do you get restorative sleep? How do you feel in the morning? Is it not just you're in the bed for 8 hours, but is it a quality sleep? These are some of like the 10,000-foot thing that all the stuff that you do and your people do well, it's even more
Right.
important. It's not just, oh, get good sleep and eat healthy. And, it's like, no, like literally, if you don't, your connective tissues will have a hard time
Right.
healing. And then the gut is a big issue because of all the detoxification things. And after that level, then I kind of go into the nuances, like, do they have mast cell? Do they have dysautonomia? Like, what are like the unique things about this person's presentation that would require, a more individualized approach?
100%. 100%. Um, I teased in one of our emails, your Leave It to
Disrespected.
Beaver, which I just loved so much. So can you share with us and then I want to open up
Oh,
for
yeah.
questions from our people, but what does Leave It to Beaver have to do with any of this? I just thought that
Oh
was
my gosh, leave it to be. That's right. You did put that question out there in the email as the little hook. So when I talk about, bone broth and all this kind of stuff, and people just glaze over, they're like, oh my gosh, like who does that? I remember when I was a kid watching a episode of Leave It to Beaver, and the kids were playing, and Jen was in the kitchen making dinner, and she started 3 o'clock in the afternoon making dinner because that's what I guess you did in the 50s. And the thing about TV, you see on TV what the culture actually looks like, people are actually doing. And
right.
so Jen was making dinner 3, but she goes in the fridge, pulls out a bone, sticks it in a pot, and starts boiling water to make dinner for her family. Like it was so normative to make your own bone broth in the 1950s. It was on Leave It to Beaver. And then I remember the statistics that 30% of all meat consumption before World War II was organ meat. And all of a sudden it's like, I kind of like in the people that are hypermobile, it's like the hunter-gatherer warrior class. They can run faster, jump higher, swim quicker response times. So many elite athletes that are hypermobile. Michael Phelps, Usain Bolt, just a whole bunch of sports. But it's like if you get deficiencies in these supercritical nutrients, you're more prone to everything breaking down. So it makes some of these nutritional things that were trendy and still are trendy. Like, no, if you're hypermobile, it's not trendy. Like you need, my son's hypermobile, and I tell him he's a Maserati. It's like, you're a Maserati. You look good, you run fast, response. But if you don't do the right maintenance and you break down, it's really expensive to fix. And so it's just, and it's true. So that's kind of the way I think about my hypermobile patients, especially when the ones that have the neurodivergence, which is a whole other conversation about the relationship between hypermobility and neurodivergence.
We have a couple minutes. Can we dip into that conversation about that relationship there?
So neurodivergence, you're all extreme versions, autism, hands, which is
Yeah.
not uncommon. Asperger's, ADHD, dyslexia, and then the whole empath aspect. If you have and I've not read the why. It's just there is a 4-time increase incidence of those neurodivergents if you are hypermobile.
Right.
So it's one of those things. If you have a kid with ADHD, it's really interesting. There's a drug that's FDA approved to treat ADHD. That's clonidine. And clonidine's a blood pressure medication that blocks the effects of adrenaline. The FDA has a drug for ADHD that's treating dysautonomic ADHD. They don't call it that. They call it regular old ADHD. So that's how common this is. We have a drug actually approved by the FDA as a patch for ADHD. And we're going to the fact that kid, is their school moldy? What's their diet look like? Screen time. We know screens are bad for kids' brain. We know it activates them. This group of kids are more prone to a lot of the dopamine addictive issues related with that stuff as well. So all of a sudden, all the things we know we're supposed to do just become really more important if you're in that neurodivergent category. And it's amazing how many people fit into that category.
Well, and it just feels like it's becoming even more prevalent in everything that you have just explained. I mean, I'm also thinking of like the hereditary aspect of this, so you're thinking not only about the child, you're thinking about the parents and their
Yes.
history of things. And as you talk about something that might have been a superpower, it turns into this Achilles heel, and you might see that generationally as well as within one person's lifetime.
Well, first time I practiced, I was seeing some patients in their 60s or 70s with Ehlers-Danlos.
Yeah.
And they had pain, but they managed it and they did okay. And I'd start seeing their kids in their 50s, on chronic narcotics. Grandma didn't like narcotics, so she toughed it out, right? Their kids are getting sick in their 20s and 30s. And so it's this thing, it's like the diabetes and all these other things that are happening younger and younger. It's just the epigenetic expressions occurring younger because of whatever, the environment, toxins, chemicals, mold, pick your poison. This group is just is more sensitive to that that epigenetic effect of our environment.
Absolutely. Wow. Well, let's see. We've got a question here, or maybe this is just a comment, but any questions you all have, this is the opportunity. She says, my daughter's tattoo artist actually asked if she had EDS due to her skin, which is suspected. 5 surgeries on her wrists, most recently her shoulder, and she's only 23. Her shoulder kept dislocating for no reason. This is also interesting. Thank you. I mean, sounds, after what we've learned here, this is sounding to me like there's
do
a
a bait and score. Look up the bait and do it. You can do it at home. The bait and score is actually made for non-clinicians to do it at home, fill it out, and take it to their primary care provider and go, look, what does this mean? So it's not a diagnostic tool. It's actually a research tool, which means there are some weaknesses to it, but it's a really easy way to kind of do a 10,000-foot view.
Carrie's asking if there are basic questions we should be asking in our intake to address this outside of the bait and score.
That's where it's tricky. Like as you're going through your history, you might ask about injuries, concussions, and did you get a small concussion that took a long time to get over? Have you ever dislocated thing before? Have you ever broken anything like, oh, I tripped and fell and broke my wrist, but that shouldn't happen to a 20-year-old who's just walking around,
Right.
So it's probably a little much for this kind of thing to get into that, but those are some of the nuances. TMJ stuff, are you cracking your teeth? Are you getting root canals? And you should not be getting root canals in your 20s and 30s, right? That should be like, so it's like, what's going on in your oral, and these people also are more prone to teeth issues because of the connective tissue problems. So, so there's a lot of nuances to it, besides the ones I've already mentioned.
I think it's a question you could almost ask yourself when someone is describing, thinking about their symptoms, thinking about like, is connective tissue a piece of this puzzle? Like, are things not being held together right?
Well, the bigger question is if you have these these seeming unrelated issues I've mentioned already, like the mast cell and the whole, if someone has 2 or 3 or 4 or 5 of those, then my thing is that you have to, at that point in time, in my mind, and I have the advantage I see people in person, so I can actually do the evaluation on them. But my thing is like, you have to prove to me you're not hypermobile at that stage.
Right. Interesting. Yeah. Natasha asks if this could lead to nerve issues and pins and needles feelings in hands.
Yes, it's indirectly related to that because of that neuropathy stuff I was mentioning. So yes.
Yeah. Okay. Essie asks, you mentioned some medications that clients could be on that would help us start thinking of hypermobility. What are some of those meds?
I said that meds you could be on, they make you think hypermobility.
I don't remember that either. So maybe there was
maybe EDS.
Oh,
Meds you would be on that made me think hypermobility. I mean, there's associated illnesses if someone's on, it's like, for example, someone's taking this. I did not say this. Maybe I either was misunderstood or I was talking fast and said something I didn't mean to say. So I don't recall that. But, there are, for example, people with anxiety who are on benzos or clonidine. Benzos actually are also mast cell stabilizers. So if you have a patient who literally like takes a small amount of a benzo, like a Xanax or whatever, they stop it, they go bonkers. They can't wean off of it. The typical doctor is like, you're addicted. And it's like, no, if you're actually addressing some of your mast cell issues, these patients literally, this works amazing for their sleep because of the mast cell issues. If people on patients like Lyrica for sleep, Neurontin for sleep, Seroquel for sleep, there's a dysautonomic part of that and a mast cell component of it that those drugs can treat. But I don't personally remember saying that in our conversation.
yeah. Oh, this is a great question. Courtney is asking, do you have a cheat sheet of things to be cautious with? Like if you see flags in our intake or initial client interviews that we would otherwise consider safe or even good advice. For example, you mentioned avoiding rebounders with certain historic symptoms and clues.
Yeah, that's like that. That's the yoga stuff. That's some of those extreme things. Diets. If you're hypermobile, being a vegan is the worst idea ever. Like literally, you will make yourself crazy sick. And so that I don't keep up with popular trends, but that for a while that was like really super popular. And it's like that's like a bad trend, or I'm going to be no meat for whatever. I'm like, I get, detoxing, et cetera, et cetera. But if your body needs more protein and you need more trace minerals, doing that is not a good idea. You need more, organ meat and related things in your life, not less.
Yeah. It's funny because I said there were two things that chiropractor told me. I was vegan at the time. So she said, you have to start eating meat and you have to stop doing hot yoga. I actually
It saved your life.
started eating meat right away, but I did. She did. She had a huge impact on me. I started studying nutrition not long after, and I was like, sort of all came together. Suzanne says, beyond the scope of our support, are there other practitioners we can refer our clients to when we suspect hypermobility is a factor? Such a great question, because you specialize in this, you recognize this, but we know that even in the functional world, not many people are aware of this. So you probably have a wait list, months and years long. So any people that you know of, or any resources that we can send people to?
The resources I would probably there's a couple of podcasts. One is Bendy Body, which is actually an anesthesiologist who's hypermobile, who interviews people. That's probably one of the better resources as far as learning, because she's had Dr. Afton on there. She's had a lot of other medical doctors. She has a lot of physical therapists. It has a focus on dance, because she was a dancer, and there's a lot of dancers in the hypermobile are diagnosed with EDS. The problem with this is I feel like this is where mold was like in the early 2000s, where it's like kind of weird, it's kind of fringe. Is it really a thing? Probably not. Only weirdos do this, blah, 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 blah. And like in 20 years, we'll all be saying, oh, because it's just one of those common things. Like even mast activation syndrome, which was like hooey weirdo-ness like 8 or 10 years ago. Now it's like, oh yeah, MCAS, everybody's an MCAS specialist now, right? So so I saw someone ask a question about so that would be like the one podcast. There's a book, it's a little thick, called Disjointed, and it's a great resource. It might be a good resource for your group to look at, because it actually walks through, physical therapy, splinting, nutritional stuff, mast cell, dysautonomia, POTS. It actually walks through almost all the things I talked about, and it's written by medical doctors, naturopaths, physical therapists, nutritionists. There's a whole host of people who got together to write this book as a resource for people that are hypermobile. It, of course, focuses on the extreme version of Ehlers-Danlos, I believe is what the title. Sorry, I'm looking at. Yeah, it mentions Ehlers-Danlos and related hypermobility, but it's a little thick. It took me probably about a month to go through it and read it, so it's a little dense, but it's a great resource on something that actually is ridiculously common.
That's a fantastic resource. Excellent. Nicole asks, is yoga not recommended, or is just not hot yoga?
You know what? I'm not a yoga expert. One of my patients is like a master Zen yoga expert, whatever. And she did 13 times of yoga, and she's hypermobile, and she's got breast implant illness and mold issues. And she has been to India and done all kinds of crazy stuff. And she does yoga and is a yoga teacher. So there are types that can be super beneficial. It's just a lot of stuff is like doing the tricks and being hypermobile, and it's very faddish, and you just got to make sure you're not doing that. And so that's where it's kind of tricky, because some places do that. So that's the reason I like Tai Chi and Qigong, because they're two mind-body practices that don't probably avoid in yin yoga. Okay, yeah. That don't do that. They're I really actually like Tai Chi, because it focuses on breath work and body awareness and movement. And the movements are actually isotonic, very slow contraction movements, which are great actually for strengthening muscle units. So I kind of prefer Tai Chi. It's just not as many resources for it as maybe say yoga.
Right. But more than there were, that's for sure. So that's a really good strategy. Stella asking, follow up on the migraine and running conversation. This feels like a personal question that someone went into my brain and asked for me, because as I said, I still get migraines and I run marathons. So it's like couldn't find a worse combination. Are there any good alternatives to running for people with migraines? Or any stabilizing that we should be doing so that we can still run if we feel like
you really should work on the better thing is not to avoid physical activity. It's to work on cervical stabilization.
Right.
So getting with a good orthopedic physical therapist, ideally someone who does like some craniosacral stuff,
Yeah.
because it's really interesting how much one of the issues that happens with hypermobility is people they get some issue with their cerebral spinal fluid draining down their aqueductus sylvius, and so they get increased pressure in their head. And one of the results is weird headaches that get worse throughout the day. You wake up first thing in the morning, you feel good. They can get weird tinnitus, weird like visual taste kind of things can go along with it. And so some of the cervical stabilization can help with a lot of those weird symptoms that are related to the hypermobility in your cervical column.
Again, you're explaining so much. I have personally gained so much from this because the cranio has always worked really well for me in that.
Yeah.
Now I
It
understand
helps
why.
with that. And it helps with like actually improving that cerebral spinal fluid flowing.
Right.
It's a really great therapy for people with hypermobility.
Oh my goodness. I have learned so much today. Thank you so much. This has been really fantastic. How can people get more of you and learn? And we've got some great resources here. I hope you're going to tell me that you're going to be working on your book. And
My book.
I know
It's after my course thing comes out, which Becky's working on right now. So
good, good.
my team's working on. So as far as me, I've got my website is my hub for education. I've got over 200 blog articles on there right now, and that's
Okay.
richmondfunctionalmedicine.com. I'm doing lots of shorts right now that I'm putting on YouTube. I actually was talking about POTS, a little too much about POTS, obviously, the last couple of weeks. Like I feel like every social media post was POTS for the last 2 weeks. My team got a little crazy with it. So
It's great stuff. It's great stuff.
Yeah.
We'll make sure that we include links to put the link in here for your website here. What's your IG handle just in there? Because it always takes us a week or two to get these processed and people want to connect with you.
The IG is it's RVA Integrative it's at RVA Integrative. It's
Okay.
Victor RVA Integrative.
Perfect.
There we go.
Awesome. Well, thank you so much. This has been wonderful. So educational. I think I know that I'm going to look at things very differently. I didn't realize how personal it was how much I'm going to look at my own health. I'm going to be thinking about this a lot tonight. This is fantastic. But thank you. Thank you for the work that you're doing. I know we're going to get a lot of people reaching out on Instagram and checking out your stuff. Thank you so much. And thank you, everybody. In 2 weeks, back here, same time, same place, we have Dan Clark. I'm sorry, I spaced on his last name for a second. He's the CEO of brain.fm. And I don't know if any of you are aware or use it. I feel like it is my focus lifeline. And he's going to talk about the impact of sound on our brains overall, and how you can use music in very specific ways to adjust focus and creativity. And it's just, it's incredible what this app does. Are you familiar, Dr. Hartman, with brain.fm?
Not familiar with that particular website now.
It's an app. It's an amazing app I mean, I literally, if you ever need to focus and you just need something to like get the focus on ASAP, it really works. So I'm really excited to dig into that with him. Thank you all. Have a great night. Thank you. I know it's very late where you are, so I will let you go. Have a good night, everybody. Thank you so much. Take care.